Good afternoon. I think we're a bit late, so let's start. I'll introduce myself at first. My name is Dr. Sohal Bayat. I'm the Director of Health Emergency in the Ministry of Public Health, Qatar. I'm also chairing this very important session, and it's my honor to do so. So, distinguished delegates, estimated speakers from the WHO, Ministries of Health, and humanitarian partners. It's an honor to welcome you in this pivotal side event on the Global Health Emergency Corps. Your presence underscores our collective commitment to strengthening health emergency preparedness and response. As a continuation of our pioneering work in establishing the Global Health Emergency Corps in the region, and as co-hosts of the GHEC side event during the World Health Assembly in '77, the Ministry of Public Health Qatar is honored to chair this important gathering. The side event offers a valuable opportunity to showcase the progress we've made toward our shared vision, strengthening health emergency workforce capacities at the regional level and ensuring global coordination. The COVID-19 pandemic laid very bare critical vulnerabilities in our health systems. The EMR, like other regions, faced profound challenges. The need for a robust, coordinated emergency workforce has never been clearer. But technology and systems alone are not enough. We must build a foundation of trust between nations, between governments and citizens, and within our own healthcare communities. This is the bedrock of effective pandemic response. The recent International Health Regulations 2005 amendments reflect a global understanding of this critical need. We must cultivate trust before crisis strikes. I'm just back with some of the colleagues here from a GHEC design workshop organized by WHO last week, where we used a scenario-based exercise to identify the common elements of the emergency workforce, surge capacities and leadership structures for health emergencies in countries, and how existing networks like the EMT initiative can come in support of strengthening and standardizing national capacities. Through the GHEC framework, countries can assess, structure, and invest in their national health emergency corps. For countries with robust health security systems like Qatar, the Global Health Emergency Corps initiative enables us to confirm that we are on the right track and is an eye-opener to workforce-related gaps that may exist. Additionally, for other countries in the region who are just starting to build health emergency workforce capabilities, the GHEC framework will serve as a tool that they can leverage to secure political buy-in to implement the initiative. The initiative aligns perfectly with Qatar's national vision, which prioritizes a resilient healthcare system, but we know that true strength lies in collaboration. No nation can face these challenges alone. By investing in the GHEC, we invest in a global network of skilled emergency responders connected through leadership, training, simulations, and ongoing partnerships. Let us seize this opportunity to build a future where we can effectively manage, mitigate health crises, and slow down, if not prevent, future pandemics, and ultimately save lives. The Ministry of Public Health of the State of Qatar is proud to champion this initiative and to collaborate in pioneering the GHEC and the regional health emergency workforce. If you allow me now, I'll introduce to you Christoph from the WHO headquarters in Switzerland to give his talk. Please, Christoph.
Thank you, Dr. Soha, for your leadership, and thanks also to your country's leadership in this Global Health Emergency Corps initiative. And let me also thank the host country and the organizers of this event, the global EMT community, for this important opportunity to talk about this initiative of the Global Health Emergency Corps. let me see if the slides, yes, they work. We have a couple of objectives with this session. First and foremost is to share with you the global vision of the Global Health Emergency Corps, but also hear from colleagues here about the adaptation of the Health Emergency Corps concept at the country level and at the regional level, particularly with focus on some of the regions, Asia Pacific and the Eastern Mediterranean region. We have it secondly as well, what we want to do with this session is demonstrate the alignment of the Global Health Emergency Corps initiative with the EMT 2030 strategy that we have been discussing overall in this gathering, and demonstrate and make clear that the emergency medical teams are a core pillar of the Global Health Emergency Corps. And lastly, also to discuss some of the opportunities for further collaboration. I think I was just listening in the earlier session here on partnerships. There is a lot that is coming out. What are the different opportunities for collaboration between EMTs and other networks? And I think this is really inspiring to see so many examples for further collaboration. Let me start first by by quoting again our Dr. Tedros yesterday in his opening remarks. He made it quite easy in identifying one of the objectives of this session to say EMTs are a vital pillar of the Global Health Emergency Corps. So that message can only be repeated further in this session here. Secondly, I think we also heard, I definitely heard Dr. Mike Ryan yesterday say that a little more complex description of the Global Health Emergency Corps is nothing more, and I think I need to read my notes here, is nothing more than the ecosystem where the different initiatives come together, recognizing that workforce is a central pillar of health emergency preparedness and response. And that's one where I want to pick up. So first, really, the Global Health Emergency Corps is part of those global efforts to strengthen health emergency preparedness and response architecture. Like many emergencies before, the COVID pandemic has triggered a lot of recommendations. WHO, when working with governments and with partners, was very clear and very adamant to make sure that all those recommendations were read in light of their validity for health emergencies at large, and not just looking at pandemics, which are massive emergencies abarking the entire world, but that happen once in a lifetime, hopefully. And not more often, but that all those recommendations are relevant for everyday health emergency preparedness and response. Hence, we like to simplify things. We like to structure and propose schematics. That's where you have seen the 5 C's, the structure of HEPR, many times referred to the collaborative surveillance, community protection subsystems, the safe and scalable care, access to countermeasures, and pulled together by the emergency coordination. Those are nothing more or less than the core capability areas identified for health emergency preparedness and response, and the health emergency workforce being a central component of that. So what are those recommendations that we've identified through the more than 300 different evaluations globally, regionally, but I'm sure also in many of your countries have done your own evaluations? Some of those points were related to the need to have, for timely action depends on the ability to have early alerts. That requires your surveillance capability to be very closely connected with your decision-making, with your emergency coordination elements. Then the second point, very critical in this forum here, the need in emergency response to have an ability to rapidly scale, to rapidly repurpose existing staff when needed, to rapidly reprogram the workforce, but also to rapidly mobilize additional rapid response capacities, EMTs being one of them, others being potentially public health rapid response teams or logistics teams or others. So that capability of rapidly activating the additional search teams was definitely a success factor in the response, and that was highlighted particularly by the independent panel. We also saw with COVID that was one of those emergencies that very rapidly went beyond health. So it required a multi-sectoral coordination approach. That leads to the level of coordination at national level. Many times in emergencies like COVID or like other health emergencies that go beyond just the health sector, it's not so clear who leads the response, who is in charge. Is it the national, who at the national level is really the decision-making authority? Where is the main coordination element? Is it with the health sector? Is it with a national committee for a health emergency preparedness response? Whatever the denominations and the nomenclature used at country level. The other key part that we're also looking at is the regional and global coordination aspect. Emergencies that affect more than one country require this level of coordination between countries, between regions, and whilst it is clear that all the decisions always will remain at country level, we've seen that there is a value in being able to coordinate better between the countries. And there are elements for formal coordination. We have many structures at sub-regional, regional levels for formal coordination. We have at the global level through the WHO World Health Assembly, through the different regional committees, through formal mechanisms. We have there's a lot of emphasis also at revising the formal levels of coordination. But we also identify the validity, and I think through this forum here we see the validity of and the value of informal coordination, informal networking, informal getting to know each other, so that, as I think quite a lot of speakers were saying earlier on, we don't need to exchange visit cards just at the beginning of the emergency. And that is at the different levels, at the levels of teams and at the level of the leadership. So how do we ensure that those levels are better connected? This is really the starting point for where we come from, the Global Health Emergency Corps Initiative. The independent panel has put it in a long, and we put in here a long quote, but the main aspect here to highlight is it is the call for a transformed global system that is better connected and more able to respond to the needs of the population. So for us, the starting point here is how can we make sure that our emergency workforce is more predictable, better connected, and also better coordinated. It doesn't really pass on. Let me see, yeah. So that gets me to the notion of the core. What is a core? We've often been asked to, why is this being called a global health emergency corps? And I'd like to say we don't speak about the corpse. We don't want to talk about the dead bodies, but we'd rather talk about the bodies, the living bodies. A core many times used, well, in some of the in Spanish is used for the Cuerpo de Bomberos, in French as well, the Corps Sanitaire. You have different languages that use that language very frequently, that term. Really, in English, we hear about a press corps, a body of persons that work together on a common activity. So when we're talking about the Global Health Emergency Corps, we really mean a body of persons working together to prepare for and respond to emergencies, needing to do that in a coordinated and combined and connected fashion. It's about all those different parts of the emergency response at country level that we can connect to each other. The emergency workforce, the standing capacity. Many of you in your countries probably work day in, day out on preparing and responding to emergencies. This is what we would call the standing emergency workforce for at the country level. The additional ones, others in this room probably are on rosters and have day jobs that are different. But when being called for an emergency, they can be deployed as part of the EMT or as part of our public health rapid response teams. So those would be the surge capacities. What are our capability to activate people that have different types of day jobs, but can be mobilized and are pre-trained to do this work in emergencies? And then at the level of the leadership coordination, what are the leadership coordination structures at country level? So what we try to do with through the Global Health Emergency Corps is, as Dr. Soha just explained earlier, what are those minimum common elements at country level? Can we identify, does this triangle pyramid speak to your capacity at country level? Do you have a workforce? Do you have, what are your surge capacities? What is your leadership coordination structure? Can we start having similar language across countries? Because the reason for this is really the idea of having similar structured workforces in every one of the countries. To this one here, there's no global health security without national health security. It is, the purpose of the Global Health Emergency Corps is really to say it's about national health emergency corps. And what are those common elements that we can learn from each other, but that we can also connect better for common learning, for response for connecting the right response capacities with the peer response capacities in other countries. So here really the message with that slide is really to show every country should have its own national health emergency corps. Call it however you wish. In the end, it's a structured and coordinated health emergency workforce at the country level. Now, how do we connect this regionally and globally? This gathering is a critical example of connecting the EMTs globally. You learn from each other. You've been growing massively over the last 10 years. I myself worked in the EMT initiative a couple of years ago in this, and I'm really amazed to see the huge growth in this community. There are other networks. We've heard earlier of colleagues from, I think they're probably in the room, from the Global Outbreak Alert and Response Network. They are also having their own connections, but it's what is it that we are trying to do through the Global Health Emergency Corps concept is really trying to map those connections, trying to understand the ecosystem in which we're working. And that brings me back to Dr. Ryan's message yesterday. It's the ecosystem that has massively evolved over the last couple of years, particularly with COVID, to understand how we connect the different networks regionally and globally with the capacities at country level. And how we can ensure, yes, thank you, and how we can ensure that these regional mechanisms connect to the national and support the National Health Emergency Corps at country level. We'll hear about the national level examples, and we'll hear later about the regional examples, but maybe just two last words on what you can expect from the global level. We've just recently met in a global design group workshop where we gathered experts from different regions and countries, and we were putting a framework together, a framework document together that explains further how we perceive the next steps in the implementation of the Health Emergency Corps. A second element is also, and I think a parallel session is about how we can come together between different mechanisms on providing more standard guidance on rapid response capacities. That's part of this element of how do we learn from the different mechanisms. And globally, we definitely need to make more work about how do we ensure those different dots are connected. How do we make sure that the Global Health Emergency Corps fits and is part of, relates to the discussions on the pandemic accord, the recently revised international health regulations, as well as the implementation of essential public health functions that have just recently identified health emergency management as being one of the core essential public health functions recommended in every country. I'll leave it at that and pass over to Oleg.
Thank you very much, Christoph, for sharing with us a global concept of health emergency corps and philosophy behind this new concept. My name is Oleg Strazenko, and I'm with the WHO Regional Office for Europe Health Emergencies Program, and I have a really great pleasure and honor to facilitate this panel discussion. And I would like to give a floor to our esteemed panelists to hear from you your perspectives, your insights, about how this GHEC philosophy and concept could be implemented at country level. What is the role of emergency medical teams in a GHEC? How can we expand partnership and collaboration with our colleagues at national and regional and sub-regional levels? And today we have 5 panelists, and I would like to start, and our session is split into 3 subsessions. First, we'll focus on national perspective. Second, we will discuss a little bit collaboration and partnerships. And third subsession will be about mainly regional perspective. And I would like to give a floor and invite for a first intervention Honorable Secretary Dr. Teodora Herboza, Secretary of Health, Philippines. And Dr. Teodora is working since a long time ago in Philippines on promoting universal health coverage. And under his leadership, emergency medical teams for Philippines was classified as EMT by WHO. Over to you.
Thank you, Oleg. Maybe I'll correct that because my real work is a trauma surgeon, and I developed emergency medicine and disaster programs in the Philippines. So many of the people in the teams are actually people I had trained before I became Secretary of Health. Very interesting that you talk about the global health workforce. Also, we also talk about empowering national. And we've long been able to do this in the Philippines, being a middle-income country, yet exposed to all the hazards, with strong earthquakes, typhoons, and everything. We are forced to develop our own framework, and we started off with an initial council, a coordinating council, coordination of the different agencies that actually respond in time of a big emergency. Later on, we actually improved that, and we learned that we could improve the system by passing a law, because before it was very much response-oriented. So we shifted to preparedness, and we now called it the National Disaster Risk Reduction and Management Act. And that created a national, our nickname for it is DREAM, DRRM. So we call it NDREAM Council. There's a regional, that means subnational regional councils. There are provincial councils all the way to the smallest townships. We call barangay councils. And this developed the whole national workforce that work in the field of disaster risk reduction and management. And in that sector, there is a cluster dedicated to health. And that's led by the Department of Health, wherein we create through all our hospitals, all our regional offices, DRRM teams. We actually called it the Health Emergency Management Bureau. But the workforce was mostly from our specialty, our big general hospitals. So the nurses, the doctors, the teams that were deployed. And we learned to actually put together these teams. We concentrated on very important items in the field of deploying these teams. The first is, of course, an actual needs assessment team. So we have a rapid health assessment team that would go, it's a smaller team of about 5-10 people that would actually relay to national government, this is what is needed. And then it was usually followed, if there are displaced people because of the climactic event, the displacement, the next team that is really deployed, we already know, is WASH teams. Because the WASH teams, you need water, sanitation. You can't survive without water in the first 24 hours. After this, we sent a team which is very similar to our EMT, which is the emergency and essential health medical care. Those that will provide, let's say, trauma care, initial level of care, emergencies like obstetric emergencies or other emergencies. Then we send a team the team actually, by this time, is actually a bigger team that's similar to the EMTs, which is now composed of the different aspects. The essential care, maternal and child care, public health, that means vaccinations and looking at disease surveillance and disease outbreaks, and of course, your mental health and nutrition. So we have this composite team that we've developed, and this is why we actually had an easier time to pass 3 in one verification visit, because the country had actually been doing this We even developed our own CBRN team because we're looking at industrialization in the country. But those teams require more technological capacity. The important thing is that in the Philippines, the framework is that it's not one. There are autonomous provinces, and the provinces themselves have disaster risk reduction and management teams and health teams. So what happens is during a major incident, everybody actually coordinates and collaborates. And national agencies become the lead or the support for logistics and supplies that are either pre-positioned prior to the emergency and then delivered to the site of the emergency. I think what's important is really the training. If you want to develop a global health emergency corps, is really training and preparing for the team. And that's where our money actually went. After we passed the law, the NDRIMC law, we were allocated budget for training people. So we trained those expertise that I talked about. And we added even incident command system. We added also training in terms of hazard assessment and very specific hazards, not only all hazards approach, but very specific hazards team. So we have teams, we know if it's an earthquake, we will need more orthopedic surgeons. If it's a flood, we will need more public health and disease surveillance. So we've learned this over the years, and our teams have been deployed. Even before our 3 teams were verified by WHO, we had been sending to other countries. In fact, one of the teams that was verified or accredited had been sent to Turkey during the Turkey earthquake. And we also learned a lot of things by being deployed in a winter country from a tropical country. So their clothes were not appropriate. It was good the Turkish government provided portable heaters for their portable tent because as a tropical country, we don't invest in those warm clothes. So these things will build, and I think we will be able to contribute to this global health emergency corps because of the number of hazards that happen in the country. I think this is going to be our contribution. We're now looking at a forum with our Pacific Island countries, the Pacific Island Forum, and we're holding a meeting with them to really find out how we can teach the same way we've survived in the Philippine Islands, teach them to meet up with the same climate change activities that we actually handle. I'll stand there. Thank you.
Thank you so much, Dr. Teodoro. And I would like to invite our next speaker, Dr. Gabriel Garcia Rodriguez from Mexico, who is covering 2 positions, very important positions, IHR National Focal Point and also EMT National Focal Point. And please, Dr. Garcia, share with us your insights about GHEC operationalization in Mexico and maybe some connectivities with emergency medical teams, rapid response teams. Over to you.
Thank you so much, Oleg. I prefer speaking in Spanish, so if anyone needs a translator, I can wait. So, thank you so much. I have a presentation, so if I can control. Thank you. The history of Mexico is not quite different for Philippines. So the history is very similar. And I'm going to switch right now to Spanish. Tenemos una historia muy común las Filipinas y México, y creo que inicia desde la parte de la vacunación hace ya muchas décadas, ¿no? En la época inicial de la vacunación en la región de las Américas. Entonces creo que ese es un solo comentario que es muy importante que lo sepan. Bueno, igual que Filipinas, nosotros tenemos 32 entidades federativas o estados que están organizados de forma independiente, respetando los lineamientos federales de la Secretaría de Salud. En México nos llamamos secretarías al Ministerio de Salud. Y en este andar justamente de los equipos de emergencia, cada estado tiene un equipo dedicado justamente a esta respuesta de emergencias. Inicialmente tuvimos equipos que nacieron como equipos de respuesta rápida frente a enfermedades como el cólera, ¿no? En la época de los 90s, 1991, posteriormente en el 97, con algunas inundaciones, se fortalecieron esos equipos, que eran equipos de respuesta médica epidemiológica, es decir, equipos que estaban conformados por enfermeras, por médicos, por un epidemiólogo de campo, que salían, eran conformados por 4, 5, máximo 8 personas que salían de forma rápida para abordar brotes y para abordar enfermedades transmisibles, esencialmente en las entidades federativas. Y posteriormente, cuando llegó la iniciativa de los EMT, los equipos médicos de emergencia, a México en el 2015, prácticamente hicimos el mismo ejercicio que Filipinas, hicimos un reconocimiento y un diagnóstico de las capacidades de México para poder tener, para anidar la iniciativa a lo que ya teníamos en México. Hicimos un rastreo, en aquel entonces, en el 2015, contábamos aproximadamente con 1,500 unidades médicas móviles conformadas por un equipo de respuesta rápida y aproximadamente teníamos 13 hospitales móviles que estaban desplegados en cada uno de los estados o en varios estados y que pudiéramos tenerlos como parte de la iniciativa, de tal forma que estos equipos fueron conformados así, con una visión integralista, una visión para poder tener desde la vigilancia, el monitoreo, lo comentó hace un momento Christophe, que la importancia para desplegar de forma rápida estriba justamente en las alertas tempranas que podamos tener de nuestros sistemas de monitoreo y de vigilancia en materia, por ejemplo, de fenómenos naturales, pues evidentemente desde los sistemas formales de vigilancia de meteorológica, los servicios sísmicos, pero desde el punto de vista de enfermedades potencialmente pandémicas o pandémicas, pues desde los sistemas de vigilancia epidemiológica que tendrían que estar aportando esta información, de tal forma que estos equipos ya nacieron así y la iniciativa lo que vino a hacer a México es fortalecer esa relación que se tiene para formar realmente cuerpos que puedan responder ante cualquier tipo de amenaza. De tal forma que nosotros digamos que en el 2018 teníamos el primer equipo de emergencias y justamente esta imagen del lado, ustedes pueden ver del lado izquierdo, un EMT que nosotros le decimos un equipo médico de emergencias tipo Frankenstein, ¿no? Nosotros armamos un equipo de emergencias y lo comento siempre así porque ustedes lo pueden ver, tiene equipos, sobre todo estructuras de diferentes tipos, es decir, no es estandarizado, fue un ejercicio que hicimos, que más que ejercicio fue una respuesta que hicimos ante un desastre, una disculpa, ahí dice 2019, pero es 2017, el 2017 en México un gran sismo en uno de los estados, en Oaxaca, y ahí pusimos a prueba la iniciativa. Y justamente este equipo fue conformado por estas brigadas epidemiológicas, por estas brigadas traumáticas, neurocirujanos, cirujanos, todas las especialidades. Y actualmente, ustedes pueden ver del lado derecho, tenemos evidentemente ya un equipo tipo 1 y un equipo tipo 2 que tenemos que poder certificar o acreditar en los siguientes meses. De tal forma que estos equipos rápidos de respuesta, pues evidentemente tienen una gran connotación desde la parte de la organización para la iniciativa y lo que nosotros estamos haciendo justamente desde el acercamiento con la sociedad, desde el acercamiento con las instancias gubernamentales es estandarizar esta forma de responder en los 32 estados. Estamos creando la normativa necesaria justamente a partir de la entrada de la iniciativa y de la intención del país de poder clasificar. Tenemos ya primero un mecanismo nacional de registro, tenemos identificados cuáles son los equipos que están desplegados a lo largo y ancho del país. Además tenemos, de alguna forma, estamos generando la norma oficial mexicana, es decir, un material normativo que nos va a permitir adelantarnos a poder registrarlos, pero además atender estandarizada la atención. Y pues evidentemente estos equipos nacionales han sido desplegados a lo largo y ancho del país en estos años, desde el 2017 a la fecha. Hemos tenido ahorita van a ver en la siguiente lámina, una gran cantidad de despliegues que están justamente centrados en estos conceptos, en la movilidad, en la oportunidad de despliegue, en la derivación del expertise, es decir, tener diferentes tipos o células de atención específicas que nos permiten diversificar la atención de acuerdo justamente al panorama y al diagnóstico de la emergencia que corresponda, y por supuesto los niveles de coordinación por diferentes actores, desde el nivel más local, nivel municipal, nivel estatal, hasta llevar a los niveles federales. Tenemos también implementado el sistema de gestión de incidentes en salud pública y por supuesto estamos creando un centro nacional de emergencias. Este centro nacional de emergencias estamos esperando que para el 2025 esté ya funcionando a partir del mes de enero. Justo en la mañana, en la madrugada tuve una reunión para poder ver esta parte de la estructura con el nuevo gobierno y está muy probablemente en enero tengamos ya esta estructura, de tal forma que estos equipos de emergencias, dentro de ellos están los equipos rápidos de respuesta, y no solamente desde la parte de vigilancia epidemiológica, sino incluso tenemos algunos otros acuerdos establecidos con otros sectores. Tuvimos la gran oportunidad, y digo la gran oportunidad, aunque para el paciente que en su momento tuvo esta enfermedad y posteriormente falleció, no fue la gran oportunidad de la vida, pero México nos prestó, este paciente nos dio la oportunidad, la familia, de poder establecer acuerdos transsectoriales para el tema de una salud. Descubrimos un paciente con H5N2 en humano recientemente, está publicado, lo pueden encontrar en la literatura indexada. Es el primero que publicamos a nivel, pues creo que a nivel global. No hay reportado un paciente humano con H5N2 y que tuvimos la oportunidad de desplegar equipos de respuesta rápida en las primeras 8 horas después de haberse notificado el paciente en uno de nuestros centros de atención. Y aquí la importancia justamente de tener esa conexión con los sistemas de vigilancia epidemiológica, y bien lo decía Oleg hace un momento, aparte de tener la responsabilidad un servidor de ser el punto focal nacional del Reglamento Sanitario Internacional y de ser el punto focal nacional de los equipos médicos de emergencia, también soy el responsable de la vigilancia epidemiológica nacional, de tal forma que esto nos ha permitido tener una visión integral para poder unificar los esfuerzos y tener toda la información en tiempo y en forma. Yo ya me vi que ya me pasé, voy a tratar de ser un poco más rápido. Justamente para coordinar estas acciones que se hacen en los estados, queremos tener centros estatales de emergencia que sean el espejo del nacional. Hoy empezamos con ingeniería reversa, tenemos ya 2 centros estatales de atención de emergencias que conforman toda esta visión, desde la preparación, la respuesta, la recuperación, que es muy difícil de repente abordarla desde una perspectiva de economía de la salud, para poder hacer eficientes los recursos, desplegar de forma escalonada, y de la misma forma escalonada en reversa regresar a los equipos a los tiempos de paz. Entonces, ustedes pueden ver a lo largo y ancho digamos, del país, y en estos últimos 6 años, el país ha desplegado 19 veces los equipos médicos de emergencia. 9 de esos despliegues fueron en el marco de la última pandemia de SARS-CoV-2, COVID-19, y que estamos viendo que que pues es muy probable que entremos nuevamente en las siguientes. Hemos tenido también 7 despliegues en total, hemos tenido una gran cantidad de despliegues y de ejercicios para poder tener estos equipos de respuesta y creo que desde esa perspectiva estamos abonando justamente a la formación de estos equipos desde una perspectiva de cuerpos de emergencia globales. ¿Cuánto?
Many thanks, Dr. Rodriguez. And I would like to thank both of you, representatives of Mexico and the Philippines, for sharing your experience. And now I would like to invite participants of this meeting, so in case you would like to share your perspective on implementation of GHEC concept at national level, so feel free to take the floor with a brief intervention. If not, so maybe we can proceed with our next subsession. And our next speaker is from Nepal, and I know that Nepal is very active not only in emergency medical teams, but also in the Global Outbreak Alert and Response Network. We have representatives from Nepal in the GORN Steering Committee, and maybe you can share with us your experience on how different emergency response capacities can work together. And I would like to invite Dr. Prakash Budha-Soku. He is representing Ministry of Health and Populations Nepal and also working in the Health Emergency Operations Center. Please, floor is yours. You'd like to? Yeah.
Thank you, Chair. Distinguished panelist and a distinguished participant. Since the 1 decade, being a disaster-prone countries and following the WHO framework and guidelines, we strongly prepared the preparation plan, and we are regularly responding to the disaster and emergency condition also. Now, regarding to the risk, the Nepal is a medium risk country. Even though we don't have a risk of cyclone, we have a risk of other conditions like landslide, flood, earthquake, and on the basis of that, we are medium risk countries. And regarding the ONM, that is the structure, we have 30 million people, and among the 30 million people, we are almost just 30,000 are the healthcare workers. But in every village, we have more than 60,000 voluntarily female health workers. That's why they are the pillars in every condition in Nepal. And in the federal ministry, in the provincial ministry, and in the local level also, we have a Health Emergency Operations Center. In the federal level, there is a NDRRMA that is chaired by the Prime Minister, and all the ministers and all the secretaries will be the members of that council. And similarly, in the chaired by the Home Minister, there will be the Executive Council. And that Executive Council, we have 5 ministers and all the secretaries. That's why we have a strong legislation for the disaster preparedness, response, and management. And in case of health, because in the health, this slide provides the detailed structure on the detection and response in public health emergency and disasters. In the detection, it highlights the key surveillance system for identifying public health emergencies. Indicator-based surveillance includes systems like the early warning and reporting system and other routine data-based surveillance tools we are using. And in the event-based surveillance, includes the more real-time and dynamic sources such as call centers, media monitoring, and community-based reports and inputs from the health facilities and laboratories. And in the public health emergency and disaster, In public health emergency, after verification, which ensures that the reported event is a real public health emergency, a rapid risk assessment is performed to evaluate the potential risk and scale of emergency. If the case is the disaster, requires a public health situation analysis to assess the potential health impact and needs associated with the disaster. And on the basis of that, only we are doing the response. And during the response, if that is the public health emergency, we have to respond the public healthly. That's a public health response. Activated based on the outcome of a rapid risk assessment for a public health emergency. Similarly, the clinical response triggered for the health-related disaster or emergencies requiring direct clinical intervention. For the response framework, we have a partnership and some partners, they are helping to us like government, rapid response team, and field epidemiology training program also. They are helping for us in the clinical public health emergency. And similarly, in the clinical care component, we have pre-hospital care, emergency care, hospital care, post-hospital care, and emergency medical team also. Because we are thinking as a emergency is a continuum of care. That's why it should start from the community to the pre-hospital, then hospital, then post-hospital too. That's why we have some learning resource package and a training for the post-hospital like a rehab service, psychosocial counseling, like that we are doing regularly. And in this, the response system in place of managing the public health emergency and disaster in the context of global health emergency corps. The given box are the training that supports the different steps in the detection and response in public health emergency and disaster. The health cluster, because this central hub coordinates the response between the different sectors, that is the public health, clinical response, and logistic support. It ensures that resources are properly allocated during the emergency. During the response, if that is a public health emergency response, on the detection and verification of the public health emergency, or rapid risk assessment is conducted to understand the severity and the scope of the situation. Key stakeholders such as Global Outbreak Alert and Response Network, Rapid Response Team, and Field Epidemiology Training Program are mobilized, and they are tailored down also now. That's why every local level, we have a Field Epidemiology trained persons also. And in the clinical response, we have more than 18 technical training programs. The public health situation analysis is conducted to guide the response, involves the medical intervention, and is divided into the hospital emergency, hospital, and post-hospital care. Pre-hospital care includes the first responder, ambulance driver, and the basic medical technicians. Emergency and the hospital care focus on the preparedness for the emergencies, disaster management, and the intensive care like critical care for the pediatric and the respiratory conditions. Post-hospital care ensures continuity of services after patients are discharged. That is the alternate care site also we are focusing, and we are talking with the local levels, and we are getting the alternate care site also. In the supporting agencies for the public health response, we have a Goran, I already told. Similarly, the rapid response team, that is in the every village level, and the field epidemiology training program, that is graduates, they are in every local level and every village also. This is the part of the emergency care system framework by WHO, which guides us how to develop a set of framework in the country. That's why we formalized it into the Nepali language also. You can see there is all Nepali language, because it is formalized and conceptualized in our country. This framework has pre-hospital care, hospital care, and post-hospital care. What we are seeing here is only the pre-hospital care diagram. Because from the community first responder, we are connecting to the hospital until the post-hospital. That's why now health emergency and disaster management is working day and night for the continuum of care. Because in the hospital only, if there is an emergency service improved, that is not enough. That is only the 20 to 25% of the emergency service. That's how we are working on that way. And thus, we have covered the ambulance and EMT portion. While seeing this framework, Ministry of Health and Population have identified the bystander or the layman or whoever are at the incident site should be able to contribute to a continuum of pre-hospital care framework and also contribute to the setting of public health emergencies. That's why from the community till the back to the community after the discharge of hospital. That's why we are taking care of that. Until now, we have given so many trainings, like for the hospitals, pre-hospitals, post-hospitals, and in the community also. That's why these are the trained numbers and basic emergency care, HDPRP, disaster response and plan for the hospital, and HOPE, and so many things are going on. But still we have a challenge. That's why I want to show you the challenges. I'm not going to describe in detail. Still, we have a challenges. That's why we want to way forward. First is the strengthening National Health Emergency Corps. And second is the capacity building and training, which we are doing regularly with the help of the partners also, with the help of the interministerial also, with the help of the 3 tiers of government also. And improving the disaster resilience, this is the most issue because we are the disaster-prone countries. How much resilient we are? How many patients we can treat? That way we are working on the disaster resilience system also. And similarly, we are improving our regional collaboration also. For that, all the partnership from the region, from the headquarters, from the other, everyone is needed. And finally, thank you. And I want to welcome to you Nepal, not only in disaster and emergency condition, in normal condition also, because Nepal, heaven is myth, Nepal is real. That's why, thank you all.
Thank you very much, Dr. Prakash. And I would like to invite comments from the floor. Maybe colleagues would like to share your experience on how different rapid response capacities can work together under the umbrella of GHEC. Yes, Luis, please introduce yourself.
Yeah, thanks. Luis de la Fuente, I'm Regional Advisor in charge of implementing the EMT initiative in the Americas and also supporting a piloting project in Central America about the GHEC. One thing that we are doing, for example, we are implementing a pilot project in Central America. Our approach is to start building this capacity at national level, so each country could adopt and appropriate and honor the concept of a health emergency corps. And once that they have developed this capacity at national level, they could strengthen and they could build all these partnership and collaborative leadership at regional level. The challenge that we have found is most of the time is that the terminology that we use at national level is quite different from the global level. So when we are talking about, for example, connected networks, in most of the countries, they don't understand what is a network or they use a different terminology. What is a kind of challenge I think that we need to address. No? The other is in several times at national level, there is an important turning of professionals. So every time that there is a change of government, or it's very easy that in the same Ministry of Health, we have new people that they could not be familiar with the concept. So it's very important, the awareness and to build this capacity, and in some way the countries started to adopt as a national initiative. One thing that we have found, for example, in Central America that is very interesting, first is that the different regional entities could discuss and develop resolutions or some kind of declaration where they could start to introduce not just the concept, the name, Health Emergency Corps, but the basic principles that are guiding the Health Emergency Corps. This is what happened with the preparedness, that they approved a resolution some weeks ago. The other is that we have found that the simulation exercise is the best scenario where we can put together the leaders, the responders, and everyone in a very friendly way. They could find all the gaps, challenges, and opportunities to develop this health emergency corps. No? And regarding the leadership, for us, what is key is what we are calling in Central America is the collaborative leadership. At the end, we said in our regional discussion yesterday, is so the success of the Global Health Emergency Corps or any clinical care or rapid response team is not to compete to reach out to the patient in the first position. It's how we collaborate to be sure that many of us could reach the more patients in a timely way. So it's something that we are working. Definitely, simulation exercise is a key tool for us in Central America, and it's a way where we are just ensuring that all the leaders but the responders could be more familiar and use and in some way starting to adopt the GHEC concept, or well, and HEC concept in their countries. Over to you. Thanks for the opportunity for sharing.
Thank you so much. Thank you, Luis. And on this, I would like to move to a regional perspective on GHEC concept implementation. And it's a really great pleasure to have here representatives of two regions, CRO and EMRO, Eastern Mediterranean and Southeast Asia region. And I would like to start with Dr. Sugi Pereira, who is a program area manager for emergency operations unit in CRO. Sugi, floor is yours.
Thank you very much, Oleg. How precise. So I'm making this, distinguished participants, good afternoon. I'm making this presentation on behalf of the Southeast Asia region as well as the Western Pacific region. So it's the Asia Pacific region that we're talking about and how we have adopted and adapted this GHEC into our existing frameworks. If we try to visualize our region, on the west, it's from India, Sri Lanka, Maldives, all the way to the Pacific Islands. It's a huge, vast range, different contexts, different population sizes, and with that, very different health systems, and comes a very different health emergency workforce. And if you look at the size of the region, it's close upon 50 countries, but it's almost 50% of the population. And every hazard in the textbook you have in our region. And what we have been doing in the past more than 20 years is have a common approach across the Asia Pacific called the APSEF framework that we call it now. Earlier it was APSED, basically trying to develop the health security in the region. So when GHEC came about, we didn't want to use it in a silo, but we incorporated GHEC design into our APSEF framework. You will see here how at the bottom we use the agile workforce, where we are concentrating very firmly on the National Health Emergency Corps, so that the Corps will have adaptive capabilities and capacities required to face response. And then from that agile workforce comes the connected networks, We have very strong EMTs, RRTs, GON partners, influencer centers, HEOCs, etc. in our regions. And what we want is to optimize the intra and inter-country surge networks in our region. And finally, at the top of the iceberg, the connected leadership. We want to make sure that leaders are connected, they have a trusted network, and they together implement international health regulations to ensure health security. Because ultimately, it's IHR that we all try to implement, and we need to have a trusted network. Unless the leaders are connected, and under this IHR framework, we will all agree that now it's not just about countries by themselves. No one across the world is safe until everyone is safe. So everyone has to come together ultimately. These are some strategic objectives that we have tried to develop along with the GHEC design and our APSA framework. So at the bottom, for the agile workforce, what we want is to streamline the linkages. All countries have the workforce. It's not that we are trying to create something, but we want to streamline the linkages. And in the networks, what we want to do is optimize the existing surge networks and the National Health Emergency Corps so that they can manage the impact of multiple threats and the shifts that we are seeing across our region. And ultimately for the leaders, as I said earlier, a trusted network so that we all can prepare and respond together and implement IHR through the APSAF. And with this triangle, we want to develop the enable ecosystem through our broader approach, which is the APSAF framework. Now, in these next 3 slides, what I have tried to do is show a little bit about the how part of it. We have all these triangles, squares, circles. Now, how do we translate this into practice? So this is what we have done. We have developed a work plan where we have clear activities, outputs, outcomes, and along with some indicators to measure what we are doing. And in the interest of time, I'm not going to go into details, but just to indicate, through the enabled ecosystem, we just want to increase the coherence and the collaboration. Through the leaders connected, we want to take these global developments to the national level through our regional committees, endorse this, align it with our regional committee resolutions, etc. And finally, for the coordinated networks, what we are aiming to do is primarily do a landscape analysis. We are talking about GHEC, but exactly what are we talking about? Who are we talking about? We want to identify in the different contexts, and through that, basically to identify the priorities and to identify the regional approaches to further strengthen the workforce. So this is just a bit about how we have adapted in our region, and thank you very much. Back to you, Oleg.
Thank you, Sugi. Unfortunately, our next speaker, Dr. Samar, cannot be here today in this room, so it's my pleasure to give the floor to Dr. Soha, who will present on behalf of Dr. Samar. Please.
Thank you, Oleg. As Oleg just said, that this presentation is supposed to be presented by Dr. Samar al-Mutawakkil from the Emro region. Unfortunately, she couldn't make it, so I'll be trying to present this on her behalf, and it's a short presentation. I know it's the end of the day and most people are tired by now. So if I do well, it's all on her. If I don't do so well, it's all on me. Okay, so let's go. Okay, so why in the region here? So what we want is a regional leaders networks. And the hope of that is to drive sustainable change. So in regional emergency response, including pandemic responses, success or failure usually depends on a high coordinated response supported by globally connected leaders with unique skills. So we need leaders, we need skills coming together in order for us to succeed. The second point is that leadership in the health sector is uniquely challenging, as the dynamic and rapidly changing environment during a health emergency, we all know during a health emergency, unexpected things happen. It doesn't go as planned. So what it really requires is leaders to understand the complex interaction between politics, access, finance, and local actors. In the context of pandemics, the proactive use of technology, surveillance systems, and global partnership is crucial. But these tools are rendered ineffective without a foundation of trust. Trust is the bedrock and the backbone of a successful pandemic response. In absence, fuels misinformation, fosters public resistance to health measures, and undermines the international collaboration. And I'm sure we all saw that during the COVID-19 pandemic. So what is the vision? Why the GHEC? Why do we need it in the region or in the EMRO region? The proposed regional leaders network would act as a central point. Sorry, I forgot to switch. Here we go. The proposed regional leaders network would act as a central point for the coordination of health emergency preparedness and response activities, particularly in cases of cross-border emergencies or pandemics, and be embedded into a global network of connected health emergency leaders. It would bring together key stakeholders, including government agencies, non-government organizations, NGOs, and other relevant partners to streamline communication, resource allocation, and response strategies. So this is the vision of why we want to have a GHEC. So the areas to focus on and collaborations, here we go. First of all, pandemic preparedness and response, strategic planning and coordinated action across all sectors, leveraging regional resources for effective pandemic management. Second, disaster risk reduction and resilience, strengthening health sector disaster and multi-hazard preparedness. Then, emergency health workforce development, training national leaders in threat assessment and crisis management, building a multidisciplinary cadre of emergency leaders and responders. And when we have that, it will not only impact the country or the national level, regional, and even global level, but we need it first at national level and then build it up. Coordination of surge capacities at national and regional levels, humanitarian and complex emergencies across border coordination and cooperation, where we expect a unified response to transboundary emergencies, for example, pandemics or refugee crises, and etc. We also need donor intelligence and resource allocations. We need to give donors the insight and intelligence for them to make informed decisions on where they allocate their resources. But I would add a point here is that even those recipients need all of this in order for them to also use the resources being given to them in the right places at the right time. This is the final slide where we ask you to join us in creating a more coordinated and effective emergency response. If one person is not safe, we're all not safe, so we really need to coordinate all our efforts. To realize the full potential of GHEC, our collaborative support is needed to adopt the idea and align our efforts to invest in building a prepared, interoperable, and coordinated health workforce and leaders who are connected regionally and globally. On behalf of Dr. Samar, thank you.
Thank you very much, Dr. Soha. And on this note, we have a few minutes left, and I would like to invite any comments from the floor from participants of this meeting to share with us your insights on operationalizing of the concept of a global health emergency corps and how it's been done in your country, and maybe some advices for us for implementation at regional and global levels. please. If not, I would like to close the session, and I would like to invite Dr. Soha for some closing remarks.
I'm sorry if you're fed up with me, but I promise this is the last time you'll see me today. In conclusion, as we conclude this pivotal side event, I'm filled with a sense of optimism and renewed commitment. Your presence, and actually really your presence until this time, at the end of a very long day, and active participation have enriched our discussion and strengthened our collective resolve to fortify global health emergency preparedness and response. Together, let us solidify our partnership, share knowledge and resources, and invest in the Global Health Emergency Corps. By empowering our health emergency workforce, we pave the way for a future where we can confidently and effectively manage health crises, prevent future pandemics, or at least slow them down, and ultimately safeguard lives. I extend my sincere gratitude to the EMR, GHEC Secretariat, our esteemed speakers, dedicated partners, and all participants for your unwavering commitment to global health security. Let us carry the momentum from this gathering forward as we work together to build a healthier, safer world for all. Thank you all. Thank you.